evening and welcome. My name is Melissa Mendelson and I am the Programs Director here at the Knowledge Center. We have a very exciting interprofessional program planned for you tonight, including a captivating keynote presentation and dynamic panel discussion about community health and human rights, both locally and globally. We are honored to have a number of very special guests participating in our program, representing medical, public health, and nursing perspectives. I'd like to take a moment to thank Drs. Geiger, Nicholas, Dorn, Howard, Redlener, and Zeidenstein for joining forces in the spirit of community health and engaging in our multidisciplinary conversation this evening. As you can see from the agenda, the keynote presentation and panel discussion will be followed by a Q&A session. Please write your questions down on the note sheet in your folder and hold on to them until the Q&A session begins. One final bit of housekeeping. Shortly after today's program, you will receive an evaluation via email. Please keep an eye out for this. We value your feedback and all respondents will be entered to win a prize. Without further ado, informationist Nighat Ispahani, who has been instrumental in developing the Against the Odds, Making a Difference in Global Health program, in line with the National Library of Medicine's exhibit that you all saw over there, will now introduce our renowned keynote speaker. So please enjoy the program. Nighat?
Good evening, everyone, and welcome. I'll have a brief introduction to Dr. Geiger. So Dr. H. Jack Geiger is the author, C. Logan Professor Emeritus of Community Medicine, City University of New York Medical School. He has previously served as Professor and Chair of Community Medicine at Tufts University and SUNY Stony Brook Medical Schools, and visiting Professor of Medicine at Harvard Medical School. Dr. Geiger has been involved in the civil rights movement from as early as the 1940s. He is a founder and past president of Physicians for Human Rights and Physicians for Social Responsibility. And both these organizations have received the Nobel Peace Prize. In an interview in 2013, Dr. Geiger stated this, and I quote, "The question of who got sick, why they got sick, and what happened to them, these were not just biological phenomena, but social, racial, economic, and political phenomena. That was the beginning of my sense that medicine can be an instrument of social change," end quote. So, as a physician activist, Dr. Geiger has been drawn to areas where issues of civil rights, health, and poverty intersect. He has a fierce devotion to neglected populations and has worked tirelessly to rectify gross disparities in American healthcare. Healthcare is a basic human right. Please welcome our keynote speaker, Dr. H. Jack Geiger.
Well, thank you for that introduction, first of all, and thank you for the opportunity to be here, and thank you to be participant with a wonderful panel, given all the experiences that you described. Back up, I'm shouting into it. As you can infer, I am almost totally blind and relatively newly blind. So giving a talk when I can't see the audience or much of anything else is a learning experience for me as well. And I hope we are going to get through all of this together. I will have some help up here and some help, I know, from the moderator. And as usual, when we get to slides at the end, from my wife. Let me begin with some references and a quotation. The references, probably in order of importance, are an article by Sarah Rosenbaum the head of health policy and a health policy veteran over many decades, in what I believe is the current issue of the Milbank Quarterly, that talks about not only the current status of community health centers in the United States, but the desperate risks that they are now once again facing for their survival and continuity. As she details, and as I will mention, that's an old story, but an important one. It has been going on for many years, and I have lived through all of those, but none of them seem to me as acute and threatening as the threats that exist now to their continuity, their funding, their ability to continue doing what they do now. And with a great deal of data along the way about their current status, as I think is noted in some of the program notes, there are more than almost 1,400 community health centers in the United States, and they exist in every state and territory of the Union, and they provide clinical care at more than 10,000 sites to the current estimate of roughly 26 million people, including some of the most vulnerable and needy populations in the United States in the provision of primary care. So that's an important resource. The second, for those who want to look further, there is a book published 8 months ago by a young civil rights historian, Thomas J. Ward, called Out in the Rural, subtitled A Mississippi Health Center and Its War on Poverty. I was asked to write a foreword to that, and a lot of the surviving staff of those original efforts contributed heavily to the writing of the book in terms of corrections and suggestions. But it is Tom Ward's independent work, and really important to have a volume by an objective and independent researcher, rather than the initial plan that 3 or 4 of us, participants and survivors, would write it. Tom Ward is a civil rights historian at a small liberal arts college in Louisiana. His first book was called Black Doctors in the Jim Crow South, and he knows and knew the turf of Mississippi and civil rights, and that made a great deal of difference in the adequacy of the volume. For those who have the time and can make the effort to go further and find that book. I know that libraries these days don't have many books in them, they have computers, but this is from Oxford University Press and should be available on a lot of platforms to order. Finally, and most immediately and easily, I think, there is a 22-minute video documentary on the Mississippi Health Center in general, which will be the subject of most of my remarks today, called also Out in the Rural, accomplished by a medical student and his wife, a film student, who were with us in Mississippi in the summers of 1969 and 1970. And you can find it simply by Googling the 4 words, Out in the Rural. That's where people in Mississippi describe themselves as living and coming from. Just the 4 words, Out in the Rural. That will bring up something called Vimeo.com, M with not a D, and it should be right there for playing 26 minutes, and I think you will find it interesting and illustrative of what you're going to hear about in these next several minutes. Finally, the quotation. The great iconic anthropologist Margaret Mead repeatedly warned that no one should ever underestimate the power of a small group of passionately determined people to change the world. That's true, first of all, of Sidney and Emily Clark and their colleagues, who created the first contemporary community health center, the first model of an institutionalized community health center in, of all places, apartheid South Africa in the mid-40s, just after the close of World War II. And all of us who have been involved with community health centers stand on their shoulders. One of the things we can hope for is that the tens and hundreds now of thousands of people who have worked in community centers, health centers in the US over these past decades, and in health centers overseas, will stand on the soldiers of all who have comprised the community health center workforce in these recent years and are doing so now, assuming that continuity continues to be possible. How did all this happen? Apartheid South Africa, and it was really apartheid state, but not nearly as vicious as the Afrikaner apartheid state that took power in the 1960s. But it had the same total control of non-white populations, the total attempt to move people out of the cities to the greatest extent possible in terms of having families and family structure, to move them to what was often the most useless and infertile land in the country, and a whole scattering of what were then referred to as hot spots, black spots, and tribal reserves. A great deal of what happened at Phalala, the Clark's first effort in creating a community health center in a contemporary mold, took place at that time and in that context at a Zulu tribal reserve in Natal province called Phalala, and was a model of social and biological pathology. Why did that happen? 75% of the South African population was African or Indian, that is the descendants of indentured service brought over from India to work in the sugarcane fields of Natal, and some other smaller groups of mixed race people called the Cape Colored, among other names. That's the population that produced South Africa's wealth in the main. 11 months out of every year, all of the able-bodied and some other African males signed contracts to work for 11 months in the gold mines, in the factories, in all of the productive industries of South Carolina, and had a month's vacation. And this didn't happen like 11 months in Joburg or Cape Town or wherever, and then in August everybody took off. It was scattered throughout the year, so there wasn't some great sudden mass of returned workers from the mines and factories. It was rather a steady, scattered dribble throughout the year. The rules were that they couldn't bring their families. That violated the apartheid scheme. They had to live in all-male hostels during their 11-month working periods. Predictably, this was open season for prostitution and many kinds of social disorganization and sickness. And so they came back from Cape Town and Joburg and wherever, Pretoria, to Palella, bearing syphilis, gonorrhea, tuberculosis, a variety of other infections, which of course, during that month home, were seeded into the community, and there were no health services available to them. And so Palella itself, a population of about 14,000 Zulu people, were ripe with illness. The ideal situation for a community health center, the optimal, if not the absolutely perfect, is one with an identifiable and countable target population, which could be both treated and studied, which provided primary care for the people of its target population, but which was, and was therefore enormously important individual by individual in recognizing and treating and preventing disease, but which simultaneously was always focused on population health, we would call it now, and in effect on bridging the long gap of separation between public health, population health, and clinical medicine, covering both, counting that population, surveying that population, using epidemiologic surveillance to monitor what was happening in that population and the success of its efforts. They were funded by the South African government in considerable measure, and in part by the Rockefeller Foundation and a few other philanthropic foundations. I didn't get there until decades later in 1957, at the beginning of my senior year in medical school, when the Rockefeller Foundation and its own great social epidemiologist, John Grant, offered me a scholarship to go to South Africa for a bit over 4 months, work in the flagship Palella Health Center and a urban center, Lamontville, in part of the city of Durban. Take a tutorial from Sydney and Emily Clark, now affiliated with the University of Natal Medical School, which had started finally in 1950 as the only medical school for non-whites in the country. And most of the white medical schools in Joburg and Cape Town and Pretoria and Stellenbosch taught very little about African health and the health of African populations, whereas the School of Public Health for non-whites, Africans, Indians, and some others in Durban did, and Sydney Clark became the chair of a Department of Family, Community, and Social Medicine at that medical school. I had to sign a waiver that I had promised never to register or try to register as a student at the Durban Medical School, because that would have violated apartheid before I could get the necessary visa to come to South Africa. And Palella came very close to that, and my experience at both those health centers was seminal for me. How did all of this then come to happen? Certainly that experience changed my life and my goals. As you've heard, I've been involved primarily in civil rights and human rights for a very long time. Western Reserve, and now called Case Western, was very open to that and thought that was an interesting idea. Let me scrounge every apparent month of elective time, vacation time, whatever, to make it possible for me to go. As part of that civil rights, human rights history, about 30 of us around the country, doctors in the main, had formed a group called the Medical Committee for Human Rights in anticipation of Freedom Summer, the great voting rights registration and community organizing and voting organizing effort, and brought hundreds upon hundreds of physicians, social workers, nurses, medical students, nursing students, and others to Mississippi to fan out around the state, start freedom schools, help SNCC, Student Nonviolent Coordinating Committee, and the Leadership Conference and the Congress of Racial Equality, CORE, to do their work during that summer, and started teaching both children and adults and providing a kind of medical presence for these indigenous social workers and a sort of neutralizing effect, not total, against the powers in Mississippi. In the course, I came as a field coordinator for that effort, and in the course of that experience, I looked around and said, hey, I don't have to go back to Africa, as was my goal. We have that all right here. And indeed, we did. And we had no funding initially, but we sat down and read or had explained to us the law that created the War on Poverty, the Office of Economic Opportunity, and it had been fiercely resisted from the beginning by southern states, Mississippi being the chief belly of the beast, with their understanding that this would replace their control system, their chosen gatekeepers, all their mechanisms of oppression, by giving grants and support and resources directly to minority communities. And so, as part of their lobbying in Congress, the governor, the two senators, everybody, they extracted a provision that a governor could veto any OEO project headed for their state. Sergeant Shriver, the head of the agency, could override that veto, but he spent very limited political capital in doing so, so it wasn't going to happen very often, and that was a serious limitation. Mississippi ended up with 2 health centers, 2 Head Start programs rather, as a condition of the final legislation. One controlled by the state, one controlled by liberals, mostly from outside, that had been part of Freedom Summer, just as one example. But then the Southern governors and senators looked at the resources that OEO was going to offer and thought, well, maybe we can get some of that for Ole Miss and the University of Alabama or wherever, and agreed to a provision that said, well, grants to institutions of higher education could not be vetoed. They were veto-proof. Nobody had thought, once all of this became clear to me, nobody had ever anticipated that given that arrangement, you could give a grant to an institution of higher education in Mississippi to do, in Boston, to do something in Mississippi. We just reinvented carpetbagging in order to become active in Mississippi. And went down to see the people at OEO, which had no mandate for health services, but did have freedom to do what they called research and demonstration projects, talked to the man in charge of that, Sanford Kravitz, and explained what a community health center was and why it should be part of the poverty program and how it functioned and how it would operate. And at the end of about 2 hours of my filling 3 of his legal pad pages with all of this pitch, he said, "Okay, how much do you want?" And I was having classic academic anxiety. And I said, well, what I would really like is $30,000 for a feasibility study. That's the usual dodge in academia. And he said, you can't have it. And I said, why not? And he said, because you have to take $300,000 and do it now. And the point that I'm making, really, in talking about what was then created in an all-black community called Mount Bayou in the middle of the Mississippi Delta. Our target population was the second poorest county in the United States. The mechanization of cotton agriculture had created 80% unemployment. You didn't need people to pick cotton in order to have, you didn't need sharecroppers to pick cotton because cotton agriculture had been mechanized. One double row cotton picking machine replaced about 100 people. You didn't need people to chop weeds because you could hire crop duster planes, and that went on and on. People were not only unemployed, they were desperately hungry. They were shooting squirrels and gathering pecan nuts in an attempt to eat for themselves and feed their children. They were living in squatting, really, in plantation shacks. And we decided from the beginning on a policy of relentless community organization, skilled community organization, and relentlessly aggressive action to confront the real determinants of their health, in addition to those that I've described, that were really what had to be dealt with before the phrase social determinants of health had ever entered the literature. Given those circumstances and our knowledge from doing a total community survey and a health survey of what the real needs were: clean water, sanitary privies, food, and community organization, pushing the envelope at every point that we could fathom. And so, for example, we wrote and filled prescriptions for food whenever there was a crisis, particularly with a sick infant in the family. Every town in the county had a black part of town with a black grocery store, and we made arrangements for 2 weeks initially that we would write prescriptions for food. Patients could take them to the black grocery store. They would get filled not just for the sick child or sick infant, but for all the infants as well as the mother, and charged to our pharmacy budget at the health center. This convinced the governor and the state senator, the U.S. senators, that communism had indeed come to the Mississippi Delta. The same thing had happened to Sidney Clark decades earlier when he provided free powdered milk to the children of Palaila who were beyond marasmus and into kwashiorkor. They screamed at OEO, and OEO came down and screamed at me, saying, what in God's name did I think I was doing? In effect, giving away free food and charging it to the pharmacy budget. And I said, what was wrong with that? And he said, a pharmacy budget is for drugs, for the treatment of disease, And I said, the last time I looked in the medical books, the most effective therapy for malnutrition was food. And he went away because he couldn't think of anything to say with that. So we went about providing clean water. Most people were drinking from creeks contaminated by surface privies. We found the people, an environmental engineer from Ohio, an African American, to come and head our Department of Environmental Intervention. They would take a long pipe, fill it with concrete to make it rigid, cut down a telephone pole, take half of it and install handlebars and bang the pipe into the ground. It was only 30 or 40 feet to the aquifer, put a pump on top, and pretty soon all over North Bolivar County there were red-handled pumps providing clean water for people. Otherwise, it was often a 5-mile round trip sending the kids and adults to get clean water from somewhere. Most of the plantation shacks didn't have it, or else they tended to try to catch rainfall in old pesticide barrels. We built sanitary privies together with people in the community at all of those sites. We discovered in our randomized health survey that there was an astonishing rate of fetal loss, mostly due to the fact that the steps on plantation shacks were the first things to crumble and erode away. And so pregnant women, 20, 30 times a day, were hopping down 3 feet from the front porch, and then climbing back up and then hopping down again until they had a miscarriage. We found children outside of their malnutrition burned because the only heating in the shacks was a pot-bellied stove. They would try to get close and their clothes would catch on fire. We discovered a simple intervention to build a little fence around the stove that kept children warm enough but not in danger of having their cotton clothing erupting into change. We spent 2 years full-time at the beginning in community organization. A great community organizer, John Hatch, was the first to volunteer, call me up and volunteer to come to the project, asking if all the jobs in Mount Bayou had been filled yet. He was the leading, highest paid African American in the Boston Housing Authority, and gave up that life to come to Mississippi. He had grown up in rural Kentucky and Arkansas. And when we first asked him to go scout Bolivar County, our target population, he disappeared for 6 weeks, making me frantically nervous. And when he finally did appear, I said, "John, what were you doing?" And he said, "Well, I picked cotton for 3 weeks. I lived in plantation shacks with the people there." Over those 2 years of patient community organizing, he built 10 local community health centers in the towns and hamlets, some of them appreciable in size, in North Bolivar County, each with their own priorities, each with their own program list of the things that they wanted to do. And they ultimately were formed into the North Bolivar County Health Council. And they are, and have been for decades now, the recipient of the health center grants, and they receive the grant. They are responsible for the operation of the health center. They own it. A critical change, the last thing I will mention before I show you some slides, a critical change occurred when a deal was made with one of the four successive, Nixon, Ford, Reagan, and others, who tried the block grant, the health center program, and send it back to those southern states, among others. The whole thing from OEO moved to HEW and had an independent existence in that budget. And a deal was struck in order to accommodate that threat with Reagan, to be lean and mean, to stop all of the social determinants of health, environmental and organizational interventions, and just be delivering personal medical care. That has been a major setback, and many health centers have found ways, however, to try and get past it and continue some of that work. The essential, I'll tell one more quick story. This is not without flaws and difficulties. We decided that our food system wasn't as efficient as it could be. The topsoil in the Delta is 12 feet deep, the richest land in the United States. We had people with agricultural skills. With help from another foundation, we formed what became a 500-acre cooperative farm separate from the health center, but involving many of the same people, that over the next several years produced thousands of tons of vegetables, a meat locker, all kinds of nutrition to feed the population that was at risk and in need. This was not without flaws. Last story, very rapidly. The farm co-op folks came to me and said, we know you're a city boy, but you need to understand that if there's going to be any crop this year, the first year, we gotta plant now. And that means we need tractors. And I said, I know that the foundation is going to pay for it, so we'll do it right away. There's a grant going in. Just stick it in 440 horsepower tractors to break the ground. Just stick it into the capital equipment. OEO never looks at that. So we sent it down that way. I said, stick it anywhere. It turned out that they had stuck the 4 tractors right in the middle of the obstetrical equipment. And I got this kind of deadpan call from OEO wanting to get some further information as to exactly what kind of deliveries we were planning. But we tried in every way we could think of to be relentlessly organizational and relentlessly pushing the envelope. Let me show the 4 slides that I hope in very rapid sequence. The first is something that at the beginning we saw over and over. No, the first of the 2 maps.
Yeah.
Okay. No, it's all right. That's a measure now out of date from an article we co-authored in the New England Journal of Medicine. The maps, in fact, were prepared by the journal itself. It shows the proportion of the population that is served by community health centers in each state. You will get all of that current information in the article by Sarah Rosenbaum. The second shows the ways in which community health centers and their clinical sites, and so many of them have multiple clinical sites and satellites, has a dot for every clinical site in the United States at which a community health center is taking care of people. And as you can see, it looks like a map of the United States with measles. It includes urban centers, rural centers, centers based in public health housing, centers in high schools for adolescents, centers of the widest variety of kinds and sites and services to be delivered. Small ones, big ones, richer ones, and poorer ones. a vital resource providing primary care for these populations. And the essential message, and I'll close with that and with the last slide, 2 slides, is what has been constructed here. As I've mentioned, ending the long separation of public health and population medicine from clinical medicine. And in an intuitive way, counterintuitive way, providing individual care for patients that can be life-saving at the same time that we were going after the major determinants of disease in that population. Medical care, at best, is responsible for roughly 20% of population health, but can be critical and life-saving for the individual. They are finally put together in this new kind of institution. Let me show the infant slide. This is something we saw over and over again. Children with infectious diarrhea and dehydration. This little boy is about 7 weeks old. He lives 5 pounds less than his birth weight. He is moribund, and we shaved his head and found one patent little scalp vein, and were able to begin rehydration and achievement and treatment. And yet knowing that without our other kinds of efforts, he would be back again, predictably, in 3 months or so, with the same situation from drinking contaminated water. We followed him, we saved him, we followed him, and the last picture is of that same child 4 years later. This gorgeous child surviving as a result not just of our interventions, but because we got him clean water, we got him a sanitary privy, we got him food, we got him an enormously resourceful community organization that registered to vote once we had the Civil Rights Act and Voting Rights Act, and intervened effectively to support him and other children. That's what we have to continue, that's what we're about, and I hope we can make every effort to sustain this and to keep bridging those gaps in the future. I'm sure I've run long. Thank you for your time and attention.
I now have the pleasure of introducing our distinguished moderator, Dr. Stephen Nicholas. Dr. Nicholas is a pioneer in the care of HIV-infected children and an advocate for the medically underserved in Harlem, Washington Heights, and the Dominican Republic, where his work has primarily taken place over the past 25 years. He has creative, innovative, community-based educational experiences for medical and public health students, as well as resident physicians. Dr. Nicholas is the founder and director of the Program for Global and Population Health, established in 1999, formerly known as the International Family AIDS Program, or IFAP, Global Health Program. Beginning in the 1980s, he worked as a pediatrician to care for HIV-infected children and their families in Harlem and Washington Heights in northern Manhattan. In 1999, along with colleagues, he started the first program to prevent mother-to-child transmission in the Dominican Republic. He previously served as the chairman of pediatrics at Harlem Hospital. He is currently the Senior Associate Dean for Admissions at the College for Physicians and Surgeons, PNS, and Professor of Pediatrics and Population and Family Health at the Mailman School of Public Health here at Columbia University Medical Center. Please welcome Dr. Stephen Nicholas.
Melissa, thank you for that introduction. And wonderful to see all of you here this evening. Dr. Geiger, I have known about you my entire career. I've been a pediatrician now for 35 years, and we've never met until this evening. Every time I lecture, I use one of your quotes. When we talk about social determinants of health, I use this quote. I hope you'll recognize this quote, which is, "The poor are likelier to be sick, the sick are likelier to be poor, Without interventions, the poor will grow sicker and the sick will grow poorer, and that has troubling consequences for all of us. And it's such an important way to really capsulize, I think, the message of what we're trying to do. You started your remarks, I think, with a bit of a call to arms, which I think is characteristic for anybody who is trying to address the needs of neglected populations. As I came into my career a number of years later than you did, starting in 1981, I was told that care for the poor was not going to be popular, not going to be mainstream, was really sort of an endangered species. And I've always thought, when I hear us talk about the urgency, I'm reminded of a famous doctor who was also a poet, William Carlos Williams, who of course spent his career right across the Hudson River in Passaic, New Jersey, general practitioner, took care of children and adults, delivered over 2,000 babies. And towards the end of his career, he wrote a love poem to his wife called "Something Urgent I Have to Say to You." And I think that's probably the tone that all of us have got when we talk about the work we're doing and how thrilled we are to see young faces in the crowd, those of you who are here trying to figure out what you're going to be doing with your own careers. Tonight, it's my great pleasure and honor to introduce our panelists for the evening. First, Jennifer Dorn, who's an associate professor, director of the Office of Global Initiatives, and its PAHO, World Health Organization Collaborating Center for Advanced Practice Nursing at Columbia University School of Nursing. And Jennifer and I do a lot of collaborative work together. She's one of the lecturers in our introduction to global population health. She's director of midwifery services, initiated the first freestanding maternity center in an inner city in the United States, in the Bronx, New York. So she's not only started her career in the Bronx, but then she's also done a great deal of work in sub-Saharan African countries since 2003, helping to expand the role of nurses and midwives in primary care and HIV care. She was the founding project director for the United States PEPFAR-funded ICAP Global Nursing Capacity Building Program that provides technical assistance to build nursing and midwifery capacity in 10 sub-Saharan African countries in response to the HIV pandemic. She's principal investigator for a grant to assess nursing and midwifery clinical research in sub-Saharan African and Eastern Mediterranean regions. And she's integrated her own global experiences in crisis response situations in 2 decades of teaching in midwifery and global health equity. So join me in welcoming Jennifer Dorn. Andrea Howard is the director of the clinical and training unit at ICAP. And let me say, so you just heard about ICAP with Jennifer Dorn. Dr. Howard is also working with ICAP. Now, ICAP is a wonderful and important program at Mailman that used to stand for the International Center for AIDS Care and Treatment Program. Okay, that's a big mouthful. Nobody can remember what that stands for, so it's just now known as ICAP, and one of the most important programs. It actually grew out of the work that we did at Harlem Hospital. Waf El-Sadr, Elaine Abrams, and I started. So Andrea oversees the design and implementation of clinical, laboratory, training programs for the prevention, care, and treatment of HIV, tuberculosis, related conditions in resource-limited settings in sub-Saharan Africa and Asia. Her research broadly focuses on TB and HIV integration, implementation science, migrant minors, and the HIV care continuum. She recently completed 2 implementation science studies, one in Ethiopia, one in Lesotho, aimed at defining best practices for integrating TB and HIV service delivery programs in sub-Saharan Africa. She's an associate professor of epidemiology at Columbia University Medical Center, director of the Global HIV Implementation Science Research Training Fellowship at Mailman, and she's a board-certified internist in infectious diseases and provides HIV primary care at Harlem Hospital. So join me in welcoming Andrea Howard. Erwin Redlener is President Emeritus, co-founder of the Children's Health Fund, a philanthropic initiative that he created with singer-songwriter Paul Simon to develop healthcare programs in 25 of the nation's most medically underserved urban and rural communities. He's the director and founder of the National Center for Disaster Preparedness at Columbia University's Earth Institute, which works to understand and improve the nation's capacity to prepare for, respond to, and recover from disasters. He holds professorships in health policy and management at Mailman and in pediatrics at PNS. He's a nationally recognized expert on children's health care, disaster preparedness policies, pandemic influenza, the impact and consequences of major natural disasters and related issues. He's currently a special advisor on emergency preparedness to Mayor Bill de Blasio, a number of federal agencies, including the Assistant Secretary for Preparedness and Response at the U.S. Department of Health and Human Services. And I can't think of any greater champion for the well-being of children than Erwin Redlener. So join me in welcoming him. And last but not least, Laura Zeidenstein, who has worked in full-scope midwifery service in New York City throughout her midwifery career in out-of-hospital birth centers, public health service, and private practice. She was a key participant in Midwifery of Manhattan, a private midwifery practice from 2003 through 2017. She's the former editor of the Journal of Midwifery and Women's Health. She's an associate professor and has served as program director of the Columbia University Graduate Nurse Midwifery Education Program since 2002. She's the project director of a collaborative maternal and child health project between Columbia University School of Nursing and an NGO public health system, Ganesh Asthaya Kendra. Did I get that almost right? Almost. You can see why they call it GK. Which actually in Bengali means People's Health Center. It was founded in 1972 by Zafrullah Chowdhury. Dr. Zeidenstein produced an educational video that you all should look at, because it's quite impressive, that was made available internationally to maternal child health policymakers in schools offering professional health programs. And this video offers a very compelling demonstration of the innovative GK model for training and integrating indigenous birth attendants into a healthcare system geared to meet the urgent needs of a low-resource country. So join me in welcoming Laura Zeidenstein. Well, we've got until about 6:45 for discussion and questions with the panelists, and then we're going to save about 15 minutes for questions from all of you in the audience. And Dr. Geiger, we're going to start with you because it's fascinating to hear about the early work in South Africa, followed by, of course, your really seminal work in Mississippi. And I'm wondering if you could say something about the common themes between that initial work in South Africa and the successful translation into creating and then sustaining community health centers in the United States.
Well, there were so many similarities between the status of those two populations, that is at Palela, rural Palela, and rural Mississippi, that not even that big a difference in availability of resources as compared to sub-Saharan Africa and a lot of other parts of the world, because OEO was a relatively rich resource in comparison to those that existed in Palela in the beginning. And the fact that people were suffering in the same ways and in the same situations, and that the same responses could be effective. In Palela, key people were the people that the Clarks and their colleagues trained to be demographers, epidemiologists, surveillance experts, epidemiologists, health survey analysis, and the like. Something we never could completely duplicate because it was really hard. We wanted to recruit or accommodate all kinds of volunteers, but particularly minority professionals for multiple reasons. And it was really hard to get people. We never could successfully hire a black epidemiologist to come south. The differences, and the second important step, and in retrospect, in the little foreword I wrote to the Tom Ward book, the most important things we did were educational. We established, first of all, we did our own training. We established the first training program for sanitarians and environmental interventionists in the history of Mississippi for African Americans, and we licensed the first 10 black sanitarians in Mississippi history, 2 of whom went on to earn master's degrees in environmental engineering and came back. One of them is now the chairman of the board that operates the health center. We learned in both places at the Clark's Institute for Health Affairs, for health training, and our educational programs. At the end of a decade, we had 8 people from Mississippi in medical school, at Tufts, at Brown, at the University of Michigan, at other schools around the state. We all beat on our alma maters, those of us who are physicians and dentists. We learned, in particular, the value of nurses and nurse midwives, many of whom did not have experience outside the hospital and had to learn and be trained in programs we had of working in the field. One of our most valuable mid-technology instruments was a set of pickup trucks from the General Services Administration that could accommodate a folding hospital bed and linens, a chemical commode, supply of sterile water and the necessary medications, and a public health nurse or a nurse midwife or a nurse to whom we could give field training that could ride to plantation shacks and successfully care not only for the family, but teach the mother how to safely care for a child with equine encephalitis. And you'll see that in the video. The strength that we had that was not available in South Africa in the face of such huge oppression was the strength of the poor themselves in these counties, taking care of themselves, organizing, and finding solutions of their own. If I haven't already run out of time, let me give one example. A lady named Pearlie B. Jones. I'm getting beaten on the arm to shut up. Okay.
I think that was a go for it.
All right. Okay. There was a little community called Round Lake. That was one of our 10 community health associations. It was headed by a remarkable woman named Pearlie B. Johnson, who was, while we had focused so much on children, very concerned the issues she raised of all the isolated elderly people, sick, blinded in some cases with diabetes and retinal pathology, living alone while their children and or grandchildren were up north, perhaps sending some money, but having no day-to-day support. and as well organizing for voter registration. The only meeting place in Round Lake, population 900, was the Baptist Church. And the minister in the Baptist Church got scared by all this talk of voter registration and other radical things. And he finally ended up putting a padlock on the church door and refusing to talk to Pearlie B. or any of the other agitators as he saw them, lest he get into trouble. And so Pearlie B. and the others had no place to meet. I would have been out there on a picket line with placards marching up and down and raising hell. Pearlie B. just went to the nearest large town, made a purchase, came back to Round Lake and put her padlock on the door. And then the minister had to begin to talk to them, or nobody could go to church, along with not going to voter registration. And the whole thing, in fact, got resolved. The best educator we ever had, and now I will stop, was a technically illiterate man who asked us for a microscope. We were trying to convince people that drinking water from the drainage ditch was not a good idea. And he suggested that we take a microscope and invite everybody to bring a drop of water from Nerd Creek, and he would show them what was in it. And people lined up 50 to 100 because nobody had ever looked before a microscope before in this crew. And he would put their drop in a flat of water and put their eye to the microscope and say, look at all those things crawling in there, they're gonna get you. And so we found the full spectrum of resilience and cooperation, and that was true as well in Palela, and our biggest resource.
We're going to move to our panelists in just a moment. I've got to say that in hearing some of your stories, such as reinventing carpetbagging, raising hell, charging food to pharmacy budgets, I sure wish I'd met you earlier in my career when I was chairman at Harlem Hospital. It would have probably done me a lot of good. We're going to ask each panelist briefly, and I'd like you to keep your answers a little succinct so that we can get through several questions. All of you have got various both international as well as domestic experiences, and could you reflect briefly on the linkages of your work in various communities and your work abroad? Okay. And Jennifer, we'll start with you.
Okay, thank you. I do have to say, and Jack, in hearing you speak, that I could have listened to you all night. It was like hearing a bedtime story of everything, of why I came to be me as a nurse midwife, and the care that I've tried to provide, and the teaching exchange I do with the students at Columbia University School of Nursing. It was, aha, this is why. This is why. So thank you, thank you, thank you. My path, in some ways, I grew of age during many national liberation struggles, so had a very global outlook. Little girl from Milwaukee, never having heard of this, but stepped into the world in change, and countries becoming liberated and setting up their own governments. But when I knew I had to be a midwife, which was through the birth of my own children and got the education, my path actually kind of reversed itself from what yours did, Jack, and that my first job once I graduated as a nurse midwife was being hired by Dr. Ruth Lubick, who was head of the Maternity Center Association, to build a birthing center, a freestanding birthing center in a community that had minimal resources and access to good maternal health care. And I ended up in the South Bronx in the 80s, and my journey was one of really learning from and organizing a community. And if anyone is the heroes of all of our stories, I think it's the people we serve, because it's the women and their families who I had the honor of giving care to over 20-some years who really taught me about what women in this community needed, and the best way for them to get it from us. So when we went there, just to identify the target population, in the Southwest Bronx, a third of the women had no prenatal care or one antenatal care visit by the time of delivery. It had the second highest rate for maternal and infant mortality in the country. This was a community in need. The community did not have access to good health care. And my first year there was really about learning from the community. People knew histories, the community of wonderfully rich community of African American women, women from the Caribbean, women from West Africa that expanded to Vietnam, Bangladesh, and always incorporating the latest group arriving in New York City to find a home. We were successful in building a freestanding birthing center for many different reasons. One was it was put in a community health center. So once a woman came in to get care, we had pediatrics, we had dental, we had all kinds of services to get the whole family involved in care. Secondly, we very quickly found that if the elder women in the community accepted us, their daughters would come. So we had elder women's brunches in every way that we could get elder women to explain, yes, we come from a tradition of midwifery, and we've also been educated in a whole set of competencies and scope of practice that's slightly different than traditional midwifery. And the third thing that I will say is that we found very rapidly, once we opened the birthing center, that women spent hours there. And counter to their experience in the local hospital, where they would spend hours to get seen, never by the same provider, and have to decide they just couldn't manage going for prenatal care when they had kids and work and managing a household. Women were staying, and it was because they had all been seen, but they didn't want to leave. They were talking with each other. And there it was, the Community Action Committee, which became an advisory group to the birthing center of women coming for our care. And they went from vaguely knowing about midwifery to staunchly defending and expanding what we needed, what care they needed, which led 15 years later to the opening of a comprehensive women's health center, because they decided they were never going to leave after they have their babies. So that's an example, and later on I'll mention how that trailed into my work in South Africa. But really the women themselves have been the heroes in defining what they needed and telling us how best to get it from us. They're truly our models.
Andrea?
You know, one of, I think, Dr. Geiger's earliest comments and descriptions of his work in Natal really resonated with me. A lot of my work is done in Lesotho, which is a very small country of about 2.1 million people that's completely surrounded by South Africa. And it has the lowest life expectancy and the second highest TB incident rate and HIV prevalence rate in the world. So 23% of the population is HIV positive, and the TB incidence rate is 522 per 100,000. About 3/4 of the TB patients are HIV infected. So a tremendously high burden of these diseases amongst others. And there's also a very high unemployment rate, and consequently many of the people in Lesotho cross the border into South Africa for work. And many of the men work in those same gold and diamond mines that Dr. Geiger talked about earlier. And this is creates structural barriers actually to receiving health care. Even if they do have access to healthcare services at these mines in South Africa, they're often reluctant to seek services because of stigma and fear of repatriation and lost wages. And so one of the projects that I've led is was to establish initially TB services and then subsequently HIV services for these migrant mine workers in employment bureaus that were located on the Lesotho side of the border in 3 districts where there was a lot of cross-border activities. And these were employment bureaus that would recruit men to work in the mines in South Africa, but then also were a place where they visited when they came across the border on the weekends to collect their paycheck and receive other services. And so we provided TB screening, diagnosis, and treatment services in these employment bureaus so that we could address the needs of this population. And these services were available on the weekends when they came home and the public health services in Lesotho were closed. And this project really emanated out of an articulated need of the miners, that they wanted services and suggested creating a clinic there. We demonstrated that there were better treatment outcomes amongst men that access services there, and there was an unanticipated demand from services from their family members, as well as ex-miners who were living in Lesotho, and although they had access to services in the public health system, they wanted to receive services there as well. And so the services have since expanded to include those groups. So now it's a family-centered model of care. And we've partnered, worked with the Ministry of Health to get the services accredited to provide HIV care and treatment services. And my final sort of thought about parallels is that the same way surveillance and epidemiology were so important to Dr. Geiger's work, we use implementation science to create an evidence base and demonstrate the effectiveness, the acceptability, the feasibility of these interventions, and use that evidence base to advocate for sort of ongoing programming and policy making so that these services can be scaled up nationwide and to similar settings throughout the region.
When Jack was 5, he's walking along on a street on the Upper West Side of Manhattan with his mom, and there was a guy standing there selling apples. And Jack says to Mom, "Mom, why is that man selling apples?" And it was during the Great Depression, right after the War of 1812, Jack, it was. And Mom said, "Well, nobody's got jobs, and the man has to make a living, and that's what he's doing to earn some money." And Jack said, "Well, why don't we buy some apples?" His mom said, "We don't need apples." And Jack ran up to the guy, took out his handkerchief, which he had a nickel in, and he bought apples from the guy. And his mom said, "Why did you do that?" And he said, "Because we need to do something to help him." And I think Jack's DNA was well established, and the trajectory of where he was from his very earliest years until now has been on a constant path of trying to improve the health and well-being of people everywhere, whether it's in South Africa or it's in the rural South, or his advocacy, which really encompasses greater swaths of the population, because he advocates in general for policies that make healthcare easier, and I think that's worth saying. Jack was my only true mentor, which started in the late 60s. In fact, when Jack and I first became mentor-mentoree, it was sort of unconsummated because we hadn't really met, but I was running a clinic in a similar area in rural Arkansas in the early 1970s with the same kind of problems, same kind of sort of realities being faced, same kind of challenges that had to be met that were way beyond what either of us had learned in medical school. So 3 quick points I would like to make about that. And actually, I've worked in Honduras and Guatemala and Ethiopia and so on. And I think what I'm about to say is pretty universal among all those kinds of settings, which is that, first of all, as Jack established, it wasn't just about the medical procedures, diagnosis, treatments, prescriptions that we learned about in medical school. It was a much broader understanding of the social determinants, as Jack went through very beautifully and eloquently. And that's something that is now embedded in the minds of people who practice healthcare in an environment where the social determinants are extremely prominent and extremely impactful on every aspect of a person's life, including their health status. And I think that was sort of this sort of horizontalization of medical, meaning that if you looked at a sort of a target thing with concentric circles, and in the middle would be traditional medical care, and then outside of that, dealing with the social determinants. I think we added another concentric circle there, which has to do with the other things that, and this is my second point, that have nothing to do with either nutrition or whatever. It has to do with a broader understanding of what our purpose is. And I've gotten less and less enamored of healthcare as a thing that will accomplish my own personal goal or mission, which is success, and especially as a pediatrician, it's the success of children. And part of it is being healthy, but part of it's also being educated, being protected, being nurtured, being appropriately emotionally supported. That whole gamut of issues puts healthcare and education, let's say, in the pit stop at a NASCAR race, if you can imagine that. So teachers, parents, doctors, public health providers, et cetera, are all in the pit stop. The kids, the car pulls in, and we all got to do our thing so the car gets back on track and makes it to the finish line being a successful childhood and the ability to be a productive citizen. And that's sort of the second point, that I think we need to go even beyond the public health issues of health and deal with the actual goal, which is success. A healthy kid, not educated, is in trouble. A healthy kid who ends up, incarcerated is not a successful outcome. So just take a little broader look at that. And the third point I want to make is that the issue of politics is extraordinarily important. When I was in Arkansas, we did house calls every night after clinic, and I would get a list of people that had to be visited, and this is very predominantly a poor black population in Lee County, Arkansas, and in the rainy season, I couldn't get there because the old surplus Army Jeep would get stuck in the mud. Why was there mud? Well, I was going to a cluster of black houses to do these, black-owned houses to do these house calls, and the money and the politics were owned by the very small white minority in Lee County, and they would decide with their limited budget which roads would get paved or gravel, and it wasn't the roads heading towards these houses where I need to go to work, take care of people. So my agenda became ultimately like, what the hell am I doing? I'm trying to, get through. I can't do my work as a pediatrician. So I started myself sermonizing in these tiny little Baptist churches around the county, saying, listen, this was coming out of a Jewish kid from Brooklyn talking to this very rural black population in rural Arkansas. And I was talking about the time, it's a time for change. I was citing Ecclesiastes. I was doing whatever I had to do. And butting up against clergy who would say, you know what, don't worry about now. You'll be fine in heaven. So my point was, you could actually be fine on, now as well as in heaven. They're not mutually exclusive. So, and the treatment was voting. We got to vote these guys out of office. We got to get the other guys in who actually represent you and care about your needs. You expand that to 2017, and you can imagine what I think about the role of politics in fixing healthcare. You can't fix bad healthcare with bad politics, and that's a reality. So I probably should have run for Congress, but I didn't.
Hi, I'm Laura, and it's a real honor to be on this panel, so thank you. Can you hear me? Okay. So for me and my work, I would say the links are connected to respectful relationships. Respectful relationships among team members in a healthcare team and the people that we're serving. I come at global health locally and globally, and I work as a midwife from the ancient art of midwifery and modern science, and that's really allowed me to, after almost 30 years, or maybe after 25 years that I was a midwife, I took my extremely hyper-educated self. I was invited to work in Bangladesh with a group that I knew. I grew up living in low-resource countries, and then came back and worked 20, 30 years here in the US, locally in global health, and invited back to go to Ganeshasta Kendra, which is People's Health Center, which People's Health is more my kind of public health. And their strategy, they began their health center at the beginning of Bangladesh, when the War of Independence of 1971, as a health center that was made up for freedom fighters and turned into a People's Health Center serving 1 million people with the strategy of development of women, to eradicate poverty and to promote social and health well-being way beyond medicine. And one of their strategies that I worked with and that I see as a broad link was working with traditional birth attendants, respectful relationships with traditional birth attendants, and really doing something very different than most public health policy and NGOs, which pretty much are working more towards eradicating TBAs in order to bring in skilled birth attendants only. And of course, we all want skills, but this kind of respectful relationship from midwife to midwife, from me, midwife, educated here, working with Bangladeshi midwives, and what GK had done. What GK had done had lowered their MMR, lower than the targeted goals, lower than the national 160 that Bangladesh got, down to like 120. Basically, most likely because of the qualitative, respectful relationships between the DIs and the medical team. And in that way, I was involved and sort of created classroom settings where the traditional birth attendants and the head of OB and the head of GYN and the paramedics, we were all learning skills together. That meant that the TBA could call the medical director on a cell phone in the middle of the night and be respected. And the women she was taking care of, the poor women she was taking care of, could be respected so that a transfer could happen safely. And that's basically the link I see in terms of just respectful relationships. Thank you.
So, Erwin, I think it's not necessarily a bad idea to stick to some degree to Ecclesiastes, which actually does lead into the next question, because, of course, Ecclesiastes is to some degree about vanity. And question for all of you, and we'll start with Laura and come back this way, is, and the other part I like about Ecclesiastes, thou shalt cast your bread upon the waters in 7 or 8 parts, which is also sort of what you got to do in community and global health, right? Because you don't know what's going to work. We're sitting here as academicians, and our business is to train the best possible doctors and nurses and public health and nutritionists and dentists, and if there's somebody I've forgotten, forgive me, OT, PT, et cetera. And we set up these young professionals as experts, and we send them out into the world. So all of us have been set up as experts going out in the world. So what is the role as we go out with our solutions? What's the role of the community in helping to figure out what the solutions are and moving things ahead? Laura?
Well, first of all, for me, as a midwife in the US, I didn't consider myself expert enough to go to another country, even though I had grown up in other countries, for about 25 years. Then I began to feel like I was enough of an expert to be able to learn in another country. And that's basically was my approach. Again, I had the privilege of knowing the people that started the health center when they were young leaders of the country, so I had some relationships already established. But I think that I had 25 years to learn to go with an open slate. And the first thing we did was we interviewed and talked to the traditional birth attendants, who it turns out there have not been ethnographic interviews ever until we have done that, because people who sit in their, the NGO offices literally don't know the 80% of the people who are attending the births. So again, after 25 years as a midwife in New York City, working globally in my city, I felt like I had the ability to go in a certain way as a novice, to learn to be able to respond to needs, as opposed to imposing any.
Very nicely said, Laura. Although I think you would have been ready after 6 months. Really, I think that's, you know.
This is a good group.
So when I was in Arkansas, we needed a social worker in this community, and you know, the program's actually staffed by something called VISTA, Volunteers in Service to America, which is the U.S. It was sort of a domestic Peace Corps. It's now become AmeriCorps. So I called up AmeriCorps, VISTA's headquarters, and said, I need a social worker. They don't say, we don't have any stinking social workers. We have, here's what we got. We got a sociology major. Okay. So along comes a recent Pomona graduate named Karen Blomberg, who was a sociology major. She was 21 years old. She ended up setting up the social work program. She screened 1,000 children in Arkansas for hearing, vision, and developmental disorders, and was a remarkably successful educator in the community. And I make this point is, don't undersell yourself. This is a, and I'm going to get phenomenal. I'll get thrown out of the room right now. But my daughter, who's working on women's empowerment, says, can I just say, would that be bad if what I just whispered to you, can I say this publicly?
Oh.
I will.
I think you got to now.
Okay. I whispered to my colleague, no man would ever say it took me 25 years to learn to do X. And I'm sure that a month after you finished your training, you would have been fine to adapt yourself and do what needed to be done. You're too modest, and you do phenomenal work that is internationally recognized. So I want to leave that as kind of a comment on the table, but my sense of the community, what's the community anyway? It's people who care, their families, their individuals. And so the role of the quote-unquote community is dependent on many, many different factors. It's absolutely, obviously important. But really what's important is this relationship between the provider systems and the people who live in a particular place. So everybody's got to be on board to make real progress happen. That's what Jack did in Mississippi, and many others did in other places, and what we, of course, did in Arkansas, what we're doing today in the South Bronx with a number of healthcare programs we have there. But I think the community is obviously critical, but communities can't do it alone. Communities need leadership. They need ways of kind of understanding what the issues are that need to be dealt with. And I think that's, I think it's a very complex question, actually, that in my own mind is still kind of evolving, even though I'm old.
I'm going to intervene. Erwin didn't mention it, but he has given you, without telling us, a prime example of doing well by doing good, because Karen Bloomberg ended up marrying him.
Oh, I forgot to mention that. Yeah, that's right.
Thank you.
That's right. I did. Jack, you just saved me a horrendous. Yeah. So Karen.
Oh yeah.
Yeah. Oh yeah. There's that. And actually, she was actually the third co-founder of the Children's Health Fund. She's actually its executive director right now. But that's.
Thank you, Jack, for that saving him.
Transparency, we call it, right?
Right.
Oh boy.
I'm okay this time. Yeah, they fixed it. So I would say that the role of communities is essential. It's critical, and it really needs to be participatory. I think that, you know, we can't sit in our ivory towers and be able to dictate what will work well in a community, and our interventions need to be contextual. And it's very important, and whenever we start with a project, you know, it's based upon needs that are identified by the community. And I think, you know, as medical professionals or academicians, we can bring forth evidence, you know, or lessons learned from other projects, but really need to work with the community to think about how they can be applied to a particular setting. So I think it's, and then also along the way, engaging the community, they can help to address implementation challenges and work collaboratively to develop solutions.
So I want to talk about HIV, which has been the main part of many of our careers here, not by necessity, not necessarily by choice, but by serving communities. So 90s, I'm in South Bronx, building this birthing center, doing births HIV comes into the community. And we found out by the testing of cord bloods on babies, which was one of the first means before women actually had access to getting tested, and come back with these stats. Oh, we just have had 10 babies last month born positive. We don't know who the mothers are. And we're thinking, here where the midwives were crawling on the floor and doing births, all very supportive to women, and the assistants, midwife assistants, all lived in this community saying, well, we're sleeping with the other half of this community. It created a need to get educated. The community itself said, we need to learn about HIV. And it translated into education in the community. It also translated into changing our practice, and then fighting with the first woman that was identified as HIV positive and came to us to have her baby and was told she had to go to the hospital because this was too complicated for midwives to do. So it took 6 months, pregnancy's 9 months, she came to us at 3 months. It took 6 months of us knowing exactly she was healthy. She was on AZT, which was the standard of care at the time. So we all learned exactly what she needed to do when she birthed in order to protect her and her baby. And ROB said, no, no, no. Every month I went to him and said, Joyce wants to birth here. Nope, high risk. But she's healthy. We can treat her. So I finally did talk about the community, and then I have one quick other to link it to South Africa. So finally said to Joyce, would you mind meeting with our doctor? Very quiet, shy woman, but adamant she was going to have our baby with us. And she said, oh, if you say that'll help, I'll go there. We go in, doctor reviews her chart, meets Joyce, policy was changed. So we then started to do births that were safe. We could give adequate treatment with healthy women. Fast forward to 2003, 2004, I'm in KwaZulu-Natal, King Edward's Hospital, working with midwives. Midwives were the main provider, working in community health centers, learning how to do HIV care. So when HIV comes in, like any new disease, even though it wasn't new, or epidemic, it gets centralized, right? You have to go to the tertiary hospital. Well, the majority of the population at risk was not living in a major urban center, right? But midwives were learning how to educate, how to start nevirapine treatment for a baby at first. This is during the age of denialism in South Africa, so there was no HIV virus, according to the president and the Minister of Health. Midwives became the front line, nurses and midwives, for giving care to the community and wisely relieving doctors to deal with the cases that we couldn't, right? We could give basic care, and it really rested from the community needs to get educated, to get tested, to get treated when they could, and to be able to break through stigma. And you fast forward, so I was initially hired by ICAP to do an assessment of the nurses and midwives' understanding about HIV management. And I watched, big struggle, but I watched between 2004 and 2010 the progress so that nurses could initiate and manage HIV care. And it was one major contributing piece. Distribution of medicine, of drugs to centers, more healthcare centers, change in scope of practice, policy. A lot of things came together, but it was one piece that really allowed an interprofessional team with nurses as the base of the community to get adequate care and treatment. And within 5 years, you have a 90% lowering of transmission from mother to child, and you have people initiating care, antiretroviral treatment earlier, and adhering. So a lot of studies, a lot of producing of evidence-based best practices, but to look at the community is central. That's why we're there. That's why we're here. You want to ask Jack to say something else?
Dr. Geiger, you want to weigh in on community?
Yes, indeed. One of the things you learn, and then I want to also address this question of what I'll call interprofessional relations. One of the things you learn is that the poor aren't the sort of the salt of the earth. They run the whole spectrum of personality types and decency or indecency or whatever. They're just poor, and very often without political or economic power, and a great many things beyond their control. What you learn is in doing this work anywhere in the world is the extraordinary resilience, courage, and inventiveness of some of those among them. Not just my health educator who was illiterate, but other people, including one of the most gifted people I have ever met, a woman named Elsie Dorsey, who had her first job at 8 carrying water to the people working in the cotton fields for, I think, 25 cents a day. Married at 16, raised in a sharecropper family, married at 16 to another sharecropper, had 6 kids, dropped out of high school in the 9th grade to go to work for the Student Nonviolent Coordinating Committee and doing voter registration, and then to Head Start, and then brought her kids to the health center to see what it was like. And John was so impressed she continued, but John Hatch, our community organizer, recognized that talent. When we started the farm co-op, she became the deputy director. When we moved from Tufts to Stony Brook, she was admitted to the Graduate School of Social Work with her GED in a program that we ran at the health center for people who didn't have a GED, no college credits or 1 year of high school at all. She graduated with honors, came back to Mississippi, worked for the Delta Ministry of the National Council of Churches and the Parchman Prison Project in the case of women prisoners. And then when all the kids were safely on trajectories to college, she went to Howard and earned a doctorate in social work. And then when, for a whole variety of reasons, HEO got tired of the people within the Mound Bayou elite, the black community that had never ceased trying to take us over, and a new board came, and a new board picked Elsie Dorsey as the new chief executive officer of the health center, where she had started as a part of John Hatch's community organization decades before. The community, or people in the community, understand what its needs are. When we realized early on that we couldn't keep calling community health center when people didn't know what it was, we better start treating people somehow beyond our prenatal care and our midwives and so on. We rented an empty church parsonage and used the living room for a waiting room and 2 bedrooms for examining rooms and a kitchen for a lab. And the first day, about 8 people came, and the second day about 17 people came, and the third day 97 people came. And the word had spread through the community that this meant a real need. And we called some of those patients together after a couple of weeks and say, tell us what you think about the health center. And they said, oh, we think the health center is just fine, and we're so happy to have it. But I tell you what, our kids can't go to school without shoes, and we don't have any money for shoes for kids. Do you think you could do something about that? And we did. They had a perception of the value of an institution that we were trying to provide for them, but they also had a very clear agenda of their own needs. One other comment about cooperation. And so what I'm trying to say is that the community is essential. Otherwise, it's a one-way street. It is in the old mode of one or another kind of paternalism without power. One of the great mistakes OEO made was in the beginning to have community participation only in an advisory committee, which instantly realized that it had no power and caused fights with the health centers for the next 2 or 3 years. We had to never attack granny midwives, even though we had 2 of the best in the world, and treat them with respect and reassure them, just as in Palela, they had to do the same thing with the native practitioners, the Inyangas and others who were throwing chicken bones around and whatever, but were important to people. And you could deal with that without conducting improper warfare. Finally, I wrote a grant that's still in operation for the General Electric Foundation for one of the organizations I work with that brought students to community health centers around the country for summer electives. And one of the conditions was the medical students or nursing students or PA students could not come alone. They had to come as a team of 3. And we are planning to add social work students and law students as fast as we can get to it. That was the first condition, that they learn to work as a team in the way practice is going to be shaped in the future. The second was that they had to have, in the course of their summer, structured time with the chief executive officer, with the clinical director, and a meeting of the community board, which now owns and operates the health center, so they could get some grasp of what the whole enterprise was, not just clinical encounter, which they craved, but this larger dimension of the institution and what it took to run and manage it and what it did. And I think one of our great needs is to have the kinds of non-hierarchical team teaching, but that also gives a sense of the structure of management of an institution and its purposes. I'll stop with that.
We're a few minutes over, but before we go to questions from the audience, I want to ask one final question of any of the panelists who would like to respond. We've talked about this sense of urgency of the important work that everybody is doing. I think we're also all feeling that some of this work is fragile. What needs to be done to sustain the work that you've started and that you're currently doing?
We are, well, I suspect the aid programs are in as great a danger. The global programs are in as great a danger as community health centers are now. We are required in every way we can figure out to do it, to be political, to organize, to turn out to vote, or a lot of this is going to go down the tube, and a lot of people are going to suffer in consequence.
Okay. Jennifer?
Educate students. So at Columbia University, the School of Nursing, and it's extremely unusual to be on a panel where there's 2 of us, and there's 2 of us happen to be midwives. Not happen to be, but really taking on how we're approaching education and shaking it, saying every person who graduates is going to be in the global community of healthcare. And what does that mean? What's your responsibility? Who do you give healthcare to, and how, and who do you listen, and who do you put in leadership? Who are you following? You're there to serve. So really taking apart an academic approach to nursing education and saying it's got to be updated quickly to fit the ethical responsibilities of anyone graduating from here to deal with global health equity.
Other response? Erwin?
One of the big problems America has is we're addicted to demonstration projects and pilots. We're doing things now that, Jack and I and others were doing, 40 years ago, 50 years ago. there's very little more research that needs to be done. What we need to be doing is scaling up, taking the things that work and finally getting them into full-blown, everybody gets it, everybody receives the service that are needed, and I think we just got to move there. This is called scaling up. You know, do a demonstration project. My own program in the U.S. with healthcare for very, very medically underserved children. Right now, maybe we see, I don't know, 290, 300,000 encounters a year. That's a drop in the bucket. That's negligible. And if we weren't doing advocacy in addition to that on a national basis, I'd be very frustrated by that. So scaling up what works is absolutely critical, and I have 4 words about that. What we need to do: 2020 and midterm elections. That's my prescription for finding some way of moving forward. But one final point I should make about that. Since I started actually working after my residency, it was 1971, ladies and gentlemen, there have been Democratic and Republican presidents, Democratic and Republican senates, Democratic and Republican houses of House of Representatives, and none of those permutations and combinations have really moved the needle all that much, for example, with child poverty in America. Why is that? I don't know. Jack knows, but I don't happen to know the answer to that. But this is a problem, and it's fundamentally ideological and political, and I think that's the way it needs to be addressed.
Okay, I think let's open it up to questions from the audience. There are microphones available, so if you will raise your hand and we will get the microphone to whoever's got questions. Should we start here in the front and then right behind? Yep.
God, they're so polite, these young people.
The time went so fast, actually.
What?
The time went so fast.
Oh, very fast. It was incredible.
You can just talk loudly, right? And is that?
Yeah, I'm Raj. I'm a dental student. So my question is for anyone, and is there anything that you wish you have done when you were students that could have made you better at what you're doing right now?
Next question.
We don't remember when we're students. Sorry, no.
Who would like to respond to that?
Well, I would respond. First of all, I don't think anybody should go to medical school or dental school or nursing school without having a significant experience in public health. If it was up to me, I'd make at least a year of public health mandatory for entry into any of those professional schools. It changes everything about the way you look at issues and all that. And I think if I had more formal training in that, I think it would have been better. And I think that's what I would say about that. There are other things, but I had no idea about the issues about nutrition. We barely touched on nutrition. I don't think they had nutrition then. Did they have food? Yeah, they must have something, but we never talked about it, and we never talked about politics and healthcare and all these other things. And I think if I had known what I knew now, I would have actually tried to be active in making sure those issues get covered in school and in training.
Hi. My name is, thank you. My name is Sam Carter. I'm an epidemiology and global health student at the School of Public Health. And this is my question for everyone. It seems that there's a dichotomy between those who wish to contribute to global health but feel that they must balance their contribution with other obligations, whatever those may be, and those who believe that the most just way to approach global disparity and injustice is with a wholehearted primary commitment of one's career. I think it might be clear on which side of that divide you all fall. But is it possible to accommodate both approaches, and if so, how?
Well, a lot of people do it part-time. I mean, as to the how, the first thing, I not only agree completely with Erwin about public health training, including, God knows, epidemiologic training. One of the things that changed my view at both Palel and Lamontville from the hierarchical system in which we are mostly all raised was the fact that the wall of the clinical facilities in each place were full of histograms of what was prevalent in the communities from which these patients came. So you could not examine an individual patient without thinking about what was happening in the community. I diagnosed the first case that I had ever seen of typhoid fever because I knew it was prevalent in the community. I never would have gotten there without that. We are also, there are a lot of people who take a summer off or whatever and go overseas and make a direct clinical contribution, whether in ophthalmology or whatever. Most of the time that is much better now. That didn't used to include training local people and local resources at multiple levels. But one of the first things we have to somehow find a way to alter as part of the rest of this is what's pretty unique to our country, which is burdening every professional student with a burden of debt that is going to cripple and weigh down their professional activities and its scope for the next several decades at the least. We are unique in doing that. And it comes second to me for the intervention for vulnerable children and vulnerable populations, because it is such a constraint on what we can do. And finally, we need to remember in all of this, despite how many good people are out there that train and dedicate them to us. One of the people that arrived unsummoned in Bolivar County was a Catholic nurse midwife who was 6 feet 4 inches tall. I thought she came from some Catholic basketball team, and was a rock in the community and in our service. People in the community, mostly Baptist, some other variants, referred to her simply as the lady in the Catholic dress, but understood how valuable she was to them. You'll see her in that video, by the way, if you're interested in Catholic nurse midwife basketball players.
Let's have one more response to the question. Andrea, do you want to weigh in on that?
So I don't think it's either or. I think you can do both. And speaking for myself, I think other members of the panel, as well as other faculty at ICAP, many of us, in addition to doing our global work, do have domestic activities, whether they're clinical activities or teaching activities or research activities. And I have to say that my weekly clinic at Harlem really does inform me and really does help me. The needs that the people in Harlem face are not that dissimilar to the people in sub-Saharan Africa. And so I do think that work on both hemispheres can inform the other.
Laura,
Steve, could I just make one around? Because so I've been dealing with this for a long time. So the question is, I'm in private practice. I want to be in private practice, but I'm still interested in these bigger issues, social issues and global justice, et cetera. So here's what I tell people. You volunteer when you can, and it's really, really invigorating to do that. If it's a summer, if it's a week, whatever you can do is important. The second thing is that you join something. You join your professional organization. You know, you're a pediatrician in practice. You can't give up your work and go full-time and doing global health. Join the American Academy of Pediatrics, become a voice, and make them more active as your advocate. You own the organization as a member of it. And the more people like you who join it, the more you could influence where they're going. So that's a really good surrogate way of doing things. And the other thing is just communicate. Letters to the editor, write an article, speak to your colleagues, talk to people in your social circles. All of those things matter, and you don't have to give up the rest of what you want to do with your life in order to become a responsible global citizen. I guess that's my general point.
Yes.
Laura, quick comment from you, and then we've got time for one more question.
Yes, global citizen. I think one thing about, yes, you can balance. You can definitely balance where you work and how you work. I think just like anything else, one has to be careful working globally to make sure that you have vetted who you're working with, who you're working for, what your purpose is. Because the tendency now towards global tourism and mission or missionary type global work is actually quite dangerous, because the scaling up idea means that you're working with people that and vetted into a community, that you're helping a community to scale up, not you to scale up. So I think that the rewards of working globally is actually the work that you are doing. The actual reward is in the work, and I think it's really important to be very, very conscientious and conscious.
Okay, one last question right here.
Thank you. Hi, my name is Ethel, and I'm also a student at the Mailman School of Public Health. I think my question actually follows up to what you just said right now, and I was wondering, as Dr. Howard said earlier, that interventions need to be contextual and collaborative. I was wondering if any of you faced any challenges in terms of being outsiders coming into these communities and implementing your own programs. So if you did face challenges, like how were you able to overcome them?
Well, I will say, I mean, I know I was just encouraged to have maybe started this work when I was 6 months out, but I think that one of the reasons that I've waited is that I don't think that I don't have any concept of imposing a program. So being an outsider, being an invited outsider to respond to the needs that are identified by a community, although I'm still conscious that I'm an outsider, I think there's so much to learn from that, but imposing a program, bringing a program in, I think is kind of sort of the opposite.
Quick responses from anybody else, and then we're going to give Dr. Geiger the last response.
I think, one second, Jack. I think, I also feel like have been always stuck to the principle that it has to be a program that's needed by the community and verbally and in terms of power and structure is intimately involved in. And you can do that in many different ways. I mean, one of the real growing experiences I had at ICAP was U.S. government funding and working in building capacity for nursing and midwifery education, and looking how you could dig into the grant, and my boss here was instrumental in how we did this, of how you dug into it and saw that Ministry of Health, Ministry of Education in a country, and nursing midwifery schools came together and decided which schools were going to be first. They decided they were going to manage the money. I mean, you try and at every point leverage that there's more than verbal agreement to power. Otherwise, it becomes a nice thing, but not the heart of what you're doing. So if you follow that basic principles of really community-led and who has a voice in making decisions, you will stay on a much sounder path, and you will accomplish a lot more in terms of people having higher levels of health.
Dr. Geiger, would you make the final comments?
First of all, there need to be a lot more sessions like this one as a first step, reaching a lot more people. We are mostly raised in hierarchical systems, and it's really pretty bad for us. Secondly, in terms of coming in from outside, there is a whole model that used to afflict international work a lot more than now, but also coming into strange territory, that shapes itself as we are going to teach folks what they need to know, or what we think they need to know, and fail to recognize how much they may have to teach us about what their needs are, about what are appropriate ways of responding to that, and with appropriate degrees of humility. I mentioned as an illustration Pearlie B. Robinson, the lady that put the padlock on the door, that when we first, John Hatch and his colleagues were going community to community and trying to explain about our coming community health center, her comment about that was there wasn't any doctor in that group, first of all, and secondly, they all talk funny, talking about our northern and other such accents. And we all had to have humility in the face of that, and that's not necessarily built into the patterns in which we change. I really hope that the generation of millennials that we are talking about these days, while having much of that interest, maybe not as much as in the 60s and 70s among them, learns something of these approaches and these opportunities now, and learns, again, what seems so familiar to us, what's still in the mission statements of so many medical schools, but stays only in the mission statements and doesn't get actively implemented, the lessons about the social determinants of health, what a sociologist has described as structural violence against segments of our population, and can respond accordingly. I suppose that's a wish that the work we're all doing can be assured of carrying on, but in the longer run, I'm confident of that, and I think this is a good beginning. And thank you all.
Well, I'm going to turn things over to Melissa for closing comments, but thank you to our panelists for your wonderful participation and to the audience. Melissa?
Okay. All right.
Yes, panel,
Oh,
please
okay.
stay seated.
Yeah.
Once again, a huge thank you to our keynote speaker, moderator, and panelists, Drs. Geiger, Nicholas, Dorn, Howard, Redlener, and Zeidenstein, for sharing their expertise and experiences with us here today. As we've heard today as well, it takes a village. And with that notion, a very special thanks to my Knowledge Center team. They are out there in the crowd. Some of them are on planes at other conferences. We really worked hard to make this a great experience for you, and you can see that hopefully, with all the contributions of the panel and everyone in the audience. So just calling out by name, Anna Getzelman, Nigat Isfahani, Arian Abdullah, John Ucelio, Joanna Goldberg, Anthony Pizzatola, Eric Dillala, Cam Mitchell, Alberto Furman, and Michael Kane for helping to make this program possible. As a reminder, did you want to?
Let's give them a round of applause.
Thank you, Dr. Geiger. As a reminder, please keep your eyes open for a short survey that will be emailed to you in the near future. Your feedback is very important to us, and we look forward to learning more about your future program interests as well. And again, all respondents will be entered for a chance to win a prize. We do deliver. So thank you all again for joining us and becoming a part of this discussion. Please continue this discussion. Take it back to your homes, to your school community, to everywhere that you are. And with that, please mingle, enjoy the exhibit once again, and the rest of the food. Have a good night.
Thank you.
Yeah, you're not going to move till we get this chairs.